So here we have a punch biopsy. You can see from this power, there appears to be an atrophic epidermis. And when you go in on higher power, you'll notice that there are some areas of necrotic keratinocytes, maybe some mild vacuolar interface change here at the basal layer, some other scattered necrotic keratinocytes. Here, maybe some areas of mildly thickened basement membrane. Overlying acute basket weave stratum corneum in most areas with some intermittent perikeratosis. And it looks like there are at least some areas within the interstitium that have some fine stringy blue material. It's not as thick as the solar elastosis that you'd be expecting. So on a digital slide here, you can appreciate this stringy blue material in the interstitium. Looking at the rest of the specimen, not really a significant amount of mid or deep inflammation. The subcutaneous fat looks relatively spared. And so this patient, let's say that they had muscle weakness, they had maybe some shawl sign or some heliotrope sign, holster sign, maybe some just diffuse erythema. Maybe they had Gottron's papules. So you did a biopsy of an erythematous area and you get this biopsy back supporting your clinical suspicion of dermatomyositis. So with dermatomyositis, what you're going to want to look for is subtle basal vacuolar change, some scattered necrotic keratinocytes and increased dermal mucin. Typically, they do not have an abundant amount of mid to deep inflammation. In contrast to, let's say, another autoimmune connective tissue disease, such as lupus, for example, and various forms of lupus, which we will discuss. Next case, we have a punch biopsy, and here you've got a little bit more inflammation now. There is definitely some more vacuolar interface change at the basement membrane, some other scattered necrotic keratinocytes. There's a superficial perivascular lymphohistiocytic infiltrate. It seems to be perivascular mostly here. As you go down a little bit deeper to examine, there also appears to be some mild perieccrine inflammation, some more mid perivascular lymphocytic inflammation, and just moving on to other sections to kind of compare. So definitely a good amount of basal vacuolar change, scattered dyskeratotic keratinocytes. And the clinical on this patient would be that they presented with maybe some photosensitive rash, maybe some areas that look like annular in morphology, annular rash. They had a positive ANA. They may have some positive anti-Rho antibodies in the circulation. So this was actually a case of subacute cutaneous lupus erythematosus. So another example of an interface dermatitis, you're going to have a little bit more overlying perikeratosis, which usually corresponds with the scale that you're going to see in SCLE. But to appreciate this inflammatory pattern of this vacuolar interface with some underlying perivascular, periadnexal, periecrine, lymphohistiocytic inflammation. So this would give you another example of an autoimmune connective tissue disease, but it's a little bit more robust than what you're going to see in dermatomyositis, but definitely you're going to want the clinical information to help you out here. Moving on to the next case. So in contrast to the last two cases, this particular punch biopsy has, as you can see, mid and even deep perivascular and periadnexal inflammation here. So it's quite robust. The inflammatory infiltrate is composed mostly of lymphocytes. And since we are in this category of vacuolar interface change, just to kind of relate, you're going to see some scattered vacuolar interface. You're going to see some areas of increased eosinophilic material here at the basement membrane. So it's kind of a thickening pattern at the basement membrane. Hope you can appreciate that. You see some areas of what we call follicular plugging here. So just increased keratin amounts within the follicular ostia at the base of or at the opening of the follicular ostia. You see really some sparse lymphocytic interface as you go across this entire specimen, so maybe some overlying perikeratosis. This particular patient appears to have a lot of solar elastosis, so it may be difficult to appreciate increased mucin here. But what is very impressive is this lymphocytic interface reaction pattern. So this is an example of discoid lupus, and this patient obviously would have some very scar-like plaques occurring on the face, scalp, the rest of the body. May or may not have a positive ANA. It just depends on if they have some systemic symptoms as well. But as we know, you can just have discoid cutaneous lupus presenting without a positive ANA or systemic symptoms. But it's estimated that approximately 15% of patients with discoid lupus can go on to progress to get systemic lupus. So these patients should definitely be followed. We won't get into the treatment of discoid lupus here for this lecture, as this is just focused on diagnostics here. So this is an example of discoid lupus, which is a form of cutaneous lupus. And along the theme of cutaneous lupus, we're looking at a punch biopsy. There doesn't seem to be a ton of interface change here. It's very, very subtle, if any, vacuolar interface. In fact, sometimes you're going to see vacuoles that appear to be more in the superficial dermis, and that's not true basal vacuolar change. So this is pretty void of impressive basal vacuolar change. So the epidermis seems pretty spared by whatever's happening here. But as you look at the biopsy holistically, you're going to see some superficial, mid, and deep perivascular and periadnexal inflammation. You see really nice lymphocytic inflammation around the eccrine glands, for example. In this entity, you'll also see some increased stringy, fine blue material in the interstitium. And so this is increased mucin. Putting this together, this patient may have some papules and nodules presenting with this erythematous color to it, and they may be photosensitive, they may have a positive ANA. So putting that together with this histology, you're definitely going to want to entertain the diagnosis of tumid lupus. So tumid lupus typically heals without scarring, in contrast to discoid lupus. And that's because the inflammation, once it subsides, it didn't destruct the basement membrane, as there's not a lot of interface change here. So in contrast to discoid lupus, which often heals with abundant scarring, tumid lupus actually does not have abundant scarring. So that can be pretty helpful clinically as well to help differentiate. So this is an example of tumid lupus. Keeping with the theme of cutaneous lupus here, as you may predict, we are going to see more inflammation now, not only targeting the superficial and mid perivascular compartments, but also getting into the subcutaneous layer itself. So even from this power, this looks like a pretty moderate to dense lymphoid aggregate. And so if you see this kind of lobular paniculitis with some dense lymphoid aggregates, you should definitely be entertaining lupus paniculitis or lupus profundus. So you can see that there are areas of relatively straightforward in terms of morphology lymphocytes, not severely atypical, not necessarily clonal appearing, just normal run-of-the-mill lymphocytes here. But they do kind of collect around adipocytes, and they actually do appear to often mimic a type of paniculitis-like T-cell lymphoma. And so it's useful to do some immunohistochemistry here. These cases are typically rich in CD4. They usually are going to express just a typical alpha beta receptor. And although there have been some evidence of expressing clonality in lupus paniculitis, and they're believed to maybe be existing along a spectrum of subcutaneous paniculitis like T-cell lymphoma and lupus paniculitis, all being kind of on the same spectrum. This is typically associated with a positive ANA. These Lesions will form usually on the upper arms and extremities of young female patients. That's the typical demographic. And so when you get this lobular paniculitis with some areas of lymphoid aggregate, some areas of rimming here, you'll want to definitely entertain the lupus paniculitis. Usually the CD4 expression is going to be much higher than the CD8 expression in lupus paniculitis. That's in contrast to subpaniculitis like T-cell lymphoma, which typically has more of CD8 compared to CD4. So that's just in contrast. Now, remember, lupus paniculitis may or may not have a significant interface change. So here you do appreciate some basal vacuolar change intermittently, but it doesn't always have to have it. Again, more examples of true basal vacuolar interface change, some scattered apoptotic or necrotic keratinocytes here. So this is very consistent with a lupus profundus lupus profundus or lupus paniculitis. And one helpful hint would be that on medium power, if you see a collection that looks almost like a lymphoid follicle and it's a paniculitis, to go through the answer choices and see if lupus paniculitis is an answer choice, because that is the kind of classic teaching example. Other things to point out in autoimmune connective tissue disease that is causing a paniculitis, you'll often see this diminution of the of the adipocyte morphology. You can even see some areas that appear to be forming snowflakes on a window pane, kind of like a lipomembranous change. So you can see that in both a lipodermatosclerosis and an autoimmune connective tissue disease based paniculitis. You can also have increased mucin in this example as well. So just kind of look for maybe increased mucin. It's hard to appreciate in this example. If you wanted to do a mucin stain, such as an Alcian blue, mucicarmine, colloidal iron, you could enhance maybe the visualization of increased mucin. But definitely want to put it together holistically and look for a positive ANA in this patient. Sticking with the theme of basal vacuolar change and scattered disc keratotic keratinocytes. So you see here more of the same. You've got basal vacuolar change, scattered necrotic keratinocytes. Your overlying stratum corneum is pretty much basket weave here. So when you're looking at this, you have a differential in mind. Now it's going to help to know clinically that this patient had formation of targetoid lesions, maybe after herpes infection or after getting a drug that they're allergic to. So targetoid lesions in the setting of scattered basal vacuolar change, scattered necrotic keratinocytes, and overlying basket weave stratum corneum, that strongly suggests an erythema multiforme. So you may or may not see a gradient from left to right where you're getting increased necrosis as you go from one side to the other, depending on how it was cut and depending on where exactly in the targetoid lesion it was biopsied. Over here on this half of the specimen, you can see on this bisected half, we're probably getting closer to the dusky center because you're getting a lot more epidermal necrosis here. Now, it's not completely full thickness, but it's nearing full thickness in some areas. And so you're probably getting closer to the dusky center, which correlates more with epidermal necrosis. So this is a very nice example of erythema multiforme. Usually you're going to see just some mild perivascular lymphocytic inflammation. You might find some increased dermal edema in bullous erythema multiforme, where it actually leads to detachment of the epidermis. You don't have to see eosinophils at all for it to be erythema multiforme. In fact, most cases of erythema multiforme completely lack eosinophils, even though it's a drug-induced phenomenon. So it's not an allergic eosinophilic phenomenon most often. It's actually more of a direct cell death related phenomenon, similar to Stevens-Johnson syndrome or toxic epidermal necrolysis. It is believed, though, that epidermal or that erythema multiforme runs along different molecular pathways as compared to SJS or TEN. Now, what can look very similar to erythema multiforme is a fixed drug reaction. So clinically, fixed drug reactions are going to be a lot more well circumscribed patches, circular patches that occur in the same exact area after every time of taking a medication. You're going to see basal vacuolar change across the dermal epidermal junction. If this is not the first time, you'll see some scattered melanophages, which suggests that it's a recurrent phenomenon. You're going to see some scattered eosinophils, which are difficult to appreciate in this particular digital slide, but in classic teaching examples, you'll want to see some eosinophils. Now, eosinophils being absent do not fully rule out a fixed drug, because you could have an evolving fixed drug. You could have one that's on its way out, where you still have some residual basal vacuolar change, but you don't see a lot of eosinophils. So you have to know the clinical and the morphology of the clinical, but I will say that scattered melanophages on digital slides should help you suspect a fixed drug more than, say, an EM, unless it's recurrent EM. Also, you can see that at least the distribution of the vacuolar interface change in the diskeratotic keratinocytes, or the necrotic keratinocytes, are more evenly spaced in this biopsy. You don't have any areas of significant full thickness necrosis. You can have a bullous fixed drug, again, if the papillary dermal edema is so strong and the interface destruction is so strong that you have a lift off of the epidermis. You can see even the interface reaction around the hair follicle as well. So this is an example of fixed drug reaction. Patients that start to get even more robust basal vacuolar change, you're going to be entertaining an evolving Stevens-Johnson syndrome. So here you can see that there are areas that are approaching full thickness necrosis. It's not quite there yet. So this would be kind of along the lines of an evolving Stevens-Johnson reaction. Now, what could look very similar to this, you could have even a grade 2 to 3 GVHD, depending on the clinical. So GVHD is also signified as a basal vacuolar reaction pattern with scattered necrosis. And depending on how much basal vacuolar change and necrosis you have, you'll bump up from, say, barely any detectable would be grade 1 GVHD. The more basal vacuolar change will put you into grade 2 with some detectable necrotic keratinocytes. As you get more even robust necrotic keratinocytes, maybe some early, almost appears to be bulla spaces forming, but not quite full-blown bulla yet, you'll have grade 3. And then once you actually get epidermal detachment, you'll have grade 4 acute GVHD. So although this was not GVHD, it shows a lot of similarities, and I wanted to, it shows a lot of similarities to, like, say, a grade 3, for example. So I wanted to mention that. But this was actually a case of SJS. Now you'll have to know clinical. Obviously, if the patient took a drug such as sulfa or lamotrigine or something that's typically associated with eruption of SJS, they're having diffuse desquamation of the skin, severe skin pain, no history of a bone marrow transplant, it would all fit with the evolving SJS. This isn't quite full thickness yet, but it's pretty worrisome. So to contrast that to, and I will say before I move to the next slide, you can have some superficial perivascular lymphocytic inflammation, but it's nothing impressive. Most of the action is here at the interface and above. So contrasting that to toxic epidermal necrolysis, which is essentially just the same thing as SJS, but it's, let's see here. So it's essentially the same slide as SJS, but you actually have more body surface area. So both of these were essentially the same digital slide and same diagnosis. But what I'll point out here is that you can't really tell a difference between SJS and TEN based on the slide alone. What you're really looking for is body surface area. So 30% involvement is going to be more correlating with an SJS TEN. greater than 30% is going to be TEN, and less than 30% is going to be SJS. But for all intents and purposes, it's pretty much the same diagnosis. Now, this is probably an evolving SJS TEN, but if we can show you maybe another slide that looks very similar, but you have more necrosis. So let's see if I can actually show you that. All right, so compared to the other two digital slides that we were just looking at, this one is going to be what happens when you're more evolved here. So let's see if I can get this full screen as best as possible. So whenever you have more evolved stage of necrosis, then you're going to have true full thickness necrosis. You're going to have detachment here. Let's see here. It's saying that my screen sharing is paused. Let me try to fix that. Okay, now hopefully, let's see. Let me try to share this. I apologize. All right. So here you can see what it looks like when you have full thickness necrosis. So compared to this area here, which you're seeing some scattered necrosis and you're seeing some interface vacuolar change, which is pretty confluent and resulting in detachment of the epidermis. And over here, this looks pretty similar to that last case as I showed you that was SJS TEN. But over here is where you have complete full thickness necrosis. So this is going to be helpful to get, if you're asked to look at a frozen section and you see something like this is going to be allowing you to say, yes, I do see interface inflammation with full thickness necrosis, and there's an overlying basket weave stratum corneum here. So this is very supportive of a diagnosis of SJS TEN. Now, again, I will say that because in this patient it involved more than 30% of body surface area, it was toxic epidermal necrolysis. If it was less than 30%, it would be Stevens-Johnson. Now, you can get the same type of robust change in erythema multiforme as well, but if you went straight to the dusky center, you might see a higher chance to see something like this. But this is quite diffuse here. So this was more in line with a Stevens-Johnson syndrome / toxic epidermal necrolysis. And again, you have to look at the whole body clinical as well. This patient obviously had more than 30% body surface area that was involving a lot of areas that correlated with desquamation and full thickness necrosis on pathology. We'll just kind of look at the other side, which is a bisected area. So you can again see areas of detachment here. Okay, let's go back to the last few examples. And so let's see here. The last example is actually an example of GVHD, but it's more of a chronic form of GVHD. I wasn't a fan of some of the examples of acute GVHD I had in my personal library. So what I'm looking at now here is some basal vacuolar change, as you can appreciate here. There's probably also some scattered melanocytes in here that are accentuated with a halo artifact. So it's a little bit difficult to tell 100% keratinocyte versus melanocyte here. Some of these I suspect are melanocytes, the way that they've got some stringy cytoplasm around the halo or within the halo itself. But there are some areas of scattered basal vacuolar change and maybe some scattered necrotic keratinocytes, but nothing impressive. What you should be more impressed with is the dermis here. So the dermis has areas of very thick collagen bundles. It's very acellular, and this is a sclerotic collagen. So this is an example of sclerodermoid GVHD. So this patient had chronic GVHD most likely it was after 100 days of a bone marrow transplant, but they started to develop these very sclerotic indurated plaques. And so you can even see on low power this boxy biopsy shape. So this is an example of sclerodermoid GVHD. These often will progress after a lichenoid GVHD, where you've got some lichenoid inflammation interacting with the overlying epidermis. And once it's going more into a burned out stage, you're going to develop this sclerotic collagen. So this is an example of sclerodermoid GVHD. And that is all I have for this presentation.